presentation is on managing eating disorder patients and understanding eating disorder patients for the purposes of primary hospital settings. So this is for eating disorder patients who are admitted to hospitals that are not specialized in the care of these particular difficulties, as that often is the case, especially in more regional centers where there are not specialized services available. So this is, I call it beyond the numbers, because we're not going to focus on the specifics of the numbers around, medical instability and that kind of thing, because I think that's a little bit of a separate topic. We're just going to talk about the general concerns that come up when somebody with an eating disorder is hospitalized, and how best that our colleagues and those that are entrusted with the care of these patients should kind of think of these kind of cases and how a hospitalization might benefit the patient. I wanted to start off by talking a little bit about a way of understanding what eating disorder patients are doing when they are restricting their diet or engaging in eating disordered behaviors. So one way to understand the behaviors of somebody who is suffering from an eating disorder is to think of the behaviors as a form of addiction. These disorders are not technically considered addictions, but they have a lot of overlap with addictive behaviors. So how they overlap is that patients with addictions and patients with eating disorders both have difficulty stopping the behavior, and the behaviors that they're engaging in can have serious and at times life-threatening consequences. The patients also frequently have difficulty acknowledging the seriousness of the consequences of their behavior, and there's often a form of denial involved in that. We can kind of see the behaviors as a way of coping for these patients, and I always find that a really useful position to take is that patients are always coping the very best that they can. If they were capable of coping in a different way, they would be. So it's really important to understand that these aren't kind of conscious choices that patients are making. So there's the two main eating disorders. I wanted to just kind of run through them here, just to acknowledge that eating disorders have two important categories: anorexia nervosa, which is where the behaviors in question are dietary restriction or undereating and overexercising combined, leading to weight loss that results in medically adverse effects, sort of a simple way of thinking about it. Anorexia nervosa has the highest risk of mortality of any of our DSM-5 conditions, which has been shown to be, in some studies, as high as 20%. When we look at the causes of death, half have been shown, about half that the causes of death are related to medical consequences, and a third from suicide. The next category is bulimia nervosa, and here the behaviors in question are binging, or something which is sort of obviously consuming more calories than would make sense in a sitting, and purging, the combination of these leading to problematic health and social effects. Bulimia also often has dietary restriction and overexercising, but the main features are the binging and purging. So what's the role of hospital in these kind of conditions? That's what I want to explore a little bit, in terms of a general medical hospital. So first of all, what we know is that for anorexia in particular, but also bulimia nervosa on occasion, treatment of severe and life-threatening consequences can come up. As we saw, 1/2 of the mortality of anorexia nervosa is from medical consequences, and so therefore we can expect that patients with those conditions are more likely to encounter these kind of medically adverse events. And the role of the local general hospital is critical in terms of stabilizing patients at those times. This can be a life-saving intervention. In addition, it can allow an opportunity for assessment and treatment planning in patients who might otherwise not have considered coming forward for treatment, or not have even been identified at the time of the event. Hospital can give a patient an opportunity to assess the seriousness of their condition and consider or reconsider treatment. So I'm going to talk just a little bit about medical instability, but I'm not going to get into, like I said, the numbers around it. There's a number of concerns that can come up, in particular with anorexia nervosa as the patient reaches the underweight stage, including hypothermia, bradycardia and cardiac arrhythmias, unstable blood pressure, metabolic instability, including consequences to renally in terms of kidney failure, hypoglycemia, and rapid and progressive physical deterioration is simply a way of understanding an eating disorder that's really picking up steam in terms of rapid weight loss and deterioration. Even if these critical incidents have not yet occurred, sometimes it's obvious that we're heading in that direction in terms of the degree of weight loss and change. And, of course, severe damage to tissues and organs from falls or from binging and purging, which has caused ruptures in the esophagus or the stomach. So there's a number of ways in which medical instability can occur, and hospitalization at those times or when this is imminent is certainly a part of the care that we all understand is necessary for patients with these conditions, which can become necessary. So I want to talk a little bit about voluntary and involuntary admissions, because both kinds of admissions are worth considering. When a patient is willing to cooperate with treatment, the admission can and should be carried out on a voluntary basis. We want to, at all times, respect the dignity and the autonomy of our patients, and when it's possible, especially with a strong treatment alliance, a voluntary admission is always preferable. If a patient is at risk of death, an involuntary admission is often appropriate, and a mental health certificate should be completed, which we know Forms 4 and 5 are the relevant documents to be completed. The involuntary admission is the one most known to general medical hospitals, and so that's why I'm going to be spending some time talking about it today. It often cannot be avoided in a case where it's come to severe medical compromise. But one wants to keep in mind the idea of the voluntary admission, and that not every patient who's admitted to hospital should be involuntary, because it does really change the nature of the interventions in each of these cases. But either way, whether voluntary or involuntary, an admission can be an opportunity for assessment, stabilization, and treatment planning. A voluntary admission does not need to be medically unstable, but if it's not, it does require an informed treatment team that knows how to work with a patient who is prepared to make changes. So, regardless of the kind of admission, there are going to be challenges ahead. I'm going to talk a little bit about those challenges. One of the things to understand is that because, as I mentioned at the very first slide, the behaviors have been ways that the patient has been coping. When these behaviors are interrupted, patients have significant emotional and physical reactions to the interruption. We see emotional distress rising, as if you can imagine, if this has been a way you've been coping with difficult emotions, those difficult emotions now will rise to the surface. On the one hand, that's a problem, but on the other hand, it can allow them to be addressed in the right therapeutic environment. Physical discomfort is often a very significant factor for these patients as they start to become aware of the cost that these behaviors have had on their body, and that they may start to experience pain and discomfort from changes in their body as they start refeeding, including bloating and sometimes bowel discomfort or constipation, diarrhea. Many things are possible, and we want to be addressing each of these and taking them into account in terms of making the necessary adjustments to medications and social supports. Behavioral reactions, I'll talk about in a little more detail, are also very significant. So how are we going to manage these challenges for the patients that come into the hospital? Well, I think there'll be another talk here on the therapeutic alliance, but I will address it to some degree here in the talk. But the therapeutic alliance with the patient is the most important management of all of these challenges. We want to ally with the patient and look at the eating disorder as the patient's chosen coping mechanism, but also understand that it has to be interrupted in order to save the patient's life. So therefore, connecting with the patient about that this is going to be a challenge and it's going to be difficult, but that we're going to support them through it, the most compassionate way to frame the intervention for the patient. We want to offer support and guidance to replace the coping mechanism while it's being interrupted and offer the patient those supports whenever they're prepared to receive them. Medications can palliate some of the emotional and physical discomfort. So there are medications for bloating and for some of the swelling that can happen, including diuretics and bowel protocol medications. Motility medications can help somewhat. Medications for anxiety and emotional distress, including antipsychotics sometimes in low doses, and anti-anxiety medications can certainly help manage some of the distress and discomfort, but once again, it's primarily the therapeutic alliance with the team and with individuals on the team that is the mainstay of support. So let's talk a little bit about some of the behavior, because it can be quite perplexing and challenging for nursing staff and practitioners of all sorts. What we want to understand is that as the patient becomes more emotionally distressed, their behavior can start to escalate. And a therapeutic response that's a careful balance of firmness and empathy is going to be helpful here. The safety of patient and staff is the first priority, and it's an essential part of the therapeutic alliance. Patients can put their own safety at risk sometimes, especially when they're feeling very distressed, and engage in self-harm behavior or in self-destructive behavior. They can, of course, sometimes manipulate the monitoring or their nutrition in some way, and that's in their desperate efforts to try and manage the emotions that are rising up and the discomfort. There can be sneaking of purging or of hiding food and so on. And so this is almost something we want to be expecting, and we want to be prepared to respond to it, again, like I say, with firmness and empathy. Without safety, there can be no recovery, so that's safety for the well-being of the patient, but also of staff. If a patient becomes very dysregulated, they can lash out with their words and make threats, or sometimes become physical, although that's quite rare. But again, and safety of the patient in terms of their health and safety, because they can put their own well-being at risk, is equally important, of course. When patients get dysregulated, they may end up provoking, trying to get others to attack them by attacking first, splitting the team, so blaming other people on the team, or driving wedges in terms of different practitioner points of view, or sometimes attempting to engineer a rescue by their family members or others outside the hospital, so where they blame people in the hospital and try to get themselves pulled out of hospital. Again, as much as possible, we want to be compassionate, but resist these efforts because they can put the patient's well-being at risk. Certainly, if the patient is medically stable, then that's a different situation. And so this is primarily what comes up in the care of somebody who is medically unstable and therefore not able to make voluntary decisions about their treatment. Regular team meetings are critical, and what we really want to do is include the patient and family in those meetings so that everyone can speak together and we can present, and everybody can see, so the patient and the family can see that everybody is working for the patient's well-being, and that the family can also be seen as an ally to treatment. So we really want to not conceal things from the patient and family. We want to speak openly about what's going on. Of course, teams want to meet with themselves to kind of make sure that they're all operating from the same page, and that their difficulties and differences can be resolved in a thoughtful and careful way. So I like to speak a little bit about monitoring, because keeping an eye on the patient and what the patient's up to is really very important so that we can know what is happening and what is going on with the patient's health and wellness. If they're not improving, we want to kind of have an understanding of why that is. Also for the patient's safety. Patients should be monitored closely, but as respectfully as possible, depending on their individual circumstances. We want to adjust how tightly they are monitored. Again, always respecting the patient's dignity. So again, this is going to be adjusted depending on the therapeutic alliance. When we have a sense of trust and that we have a sense that the patient's able to be honest with us, that can help us. But the patient's safety in terms of whether they're suicidal, whether they're medically compromised at the time and how compromised they are, as well as understanding, where in the past reliability has been for that patient, will all help us decide on how closely monitoring needs to be. As I say, without safety, we can't move forward. So safety is our primary concern. And as things become less severe and less critical, we want to adjust the monitoring accordingly so that we can build trust with the patient and that can move forward. And they can only move forward if we're giving the patient the opportunity to show us that they can be trustworthy. So therefore, by decreasing the frequency of monitoring is one good way of doing that. One-to-one monitoring is usually necessary at the onset of an admission. And as this is the most trying part of the stay for the patient, and they haven't yet built trust with those around them. Monitoring should be framed as support and care. So emotional dysregulation, patients have been using the disorder to regulate their emotions. And without these behaviors, dysregulation rises to the surface, emotional and physical. The patient will often plead and covertly or overtly act out. And managing the distress with the therapeutic alliance support and medications as possible in the setting is important. If the therapeutic alliance is not possible and there's no way to establish it, the admission should be kept to the length needed for medical stabilization and not longer, because it will become counterproductive and sometimes quite traumatizing. So I want to make a few points here on dignity. Patients are suffering from a severe and life-threatening condition, and they did not choose to be suffering. Sometimes there may be some choices as to how people cope, but the suffering underneath that is not a choice. Patients and families deserve to be treated with dignity, and they should never be scolded or blamed. Patients should be included as allies in treatment whenever possible and to the degree possible. And patients should be given choices when it is safe and possible to do so. And even within that time, there should always be some choices offered to patients at all times during their stay for comfort and preference. So let's talk a little bit about discharge from hospital. We want to be identifying supports for discharge as soon as possible in the hospital stay, contacting families or other supporters and bringing them into hospital to be part of the treatment planning, identifying resources in the community that can follow up with the patient upon discharge, and making sure that they have a chance to meet the patient if at all possible. So that includes medical supports for follow-up, mental health, and community supports. Now, if a patient medically stabilizes on the unit and the therapeutic alliance is maintained, it is quite reasonable to lengthen an admission beyond medical stability to allow the patient to re-nourish, prepare for discharge, organize supports, and meal plan. That can decrease the risk for relapse and readmission, and is well worthwhile for that reason. And even brief passes to practice eating in the community are ideal, so the patient can experiment with that prior to being discharged, because it can be quite a shock going from being in the hospital every day to suddenly being out entirely. So brief passes for weekends or overnights to practice is a very good idea in the transition. And that brings us to the end.